Okay, when I first on about the burden of sickle, not very good data, but estimates that around 6,000 children are born with sickle cell disease in Kenya annually. And we don't have an equal burden in the country, but we have 17 out of the 47 counties that have a high burden of sickle cell, mainly in Western Kenya and the coastal region. And the condition is not often initially recognized by families or even health workers. Instead, it's usually misdiagnosed for malaria and boils. So this burden might actually is not actually, it's very much underreported, and the burden might be higher than what is stated. As regarding prioritization, as a Ministry of Health, we try to elevate the profile of sickle cell disease, and I'll try and illustrate in what ways we've done. We have a Kenya Non-Communicable Diseases and Injuries Poverty Commission that was established in the year 2016, and the main aim of this commission was to try and get data on or information on selected NCDs, sickle cell being one of them. And lastly, it was supposed to come up with recommendations on how we reduce the burden of those 15 conditions. So sickle cell disease was one of the 15 conditions we said is a priority, especially since it has a high bearing among the poorest community in Kenya. And after the work of this commission, it was recommended that in high burden settings, we should have newborn screening followed by standard prophylaxis against bacterial infections and malaria. So the picture on your left is, the picture on the left shows the report that the commission came up with. Later on in 2018, we had an investigation case for NCDs. This time again, we also chose sickle cell disease and one of the 7 conditions where we did an investment case. We are trying to see what is the economic burden or loss attributed to these selected diseases. And for sickle cell, we saw that if we continue the way we are doing things up to the year 2030, sickle cell disease will be costing Kenyans a total of 16 billion Kenyan shillings, or an equivalent of 150 million shillings. That is the estimated loss up to the year 2030 if interventions are not scaled up. The same investment case saw that there was a current treatment gap at 90%. And the picture on the left shows the report at the end of the completion of the work. When it comes to health systems response, this diagram is showing the policy orientation or the policy objectives of a health policy that runs between 2014 and 2030. I want you to concentrate on the column in the middle, where that it talks about the objectives of the policy. We have 6 objectives, and objective number 2 is on halting and reversing the burden of NCDs, which includes sickle cell disease. So in it, we've made provisions for various interventions, ranging all the way from prevention to management, showing that at least for us, sickle cell and NCDs is a priority to the country. When I come to some of the building blocks for health systems, and I'll start with leadership and governance, we do have a blueprint for non-communicable diseases. We've had one, the NCD strategic plan, running between 2015 and 2020. And the current one is on draft form that will run between 2021 and the year 2025. We have expanded the scope to include sickle cell disease, not just what WHO recommended, the 4 main communicable diseases, but in line with what was decided in the Brazzaville Declaration, we also included sickle cell and other hemoglobinopathies. We also do have a sickle cell technical working group that governs the programming of sickle cell disease in the country. And at the Ministry of Health, we do have a sickle cell disease, which has a focal person, and that is currently myself. When it comes to human resource or health workforce, we are trying to do a curriculum for training healthcare workers mainly primary healthcare level, in line with universal health coverage, because we want to ensure that services are closer to persons living with disability, with sickle cell. So we are in the process of incorporating the sickle cell disease module into the overall module for NCDs. Another thing we are also doing is development of training manual for community health volunteers, that's CHVs. So we want at least the CHVs to be able to do an aspect of health promotion education, and also to refer and patients who they seem to refer people who might be suspected to have sickle cell disease, and also to provide proper health education or self-care for persons living with sickle cell disease. Lastly, we also do continuous medical educations, and we have webinars in a bid to provide some training to our healthcare workers. Okay, this picture is just showing a poster of a recent webinar we had last year. It was about training on multidisciplinary approach in the management of sickle cell. So we do have such trainings, and recently in the advent of COVID, we have these trainings once in a while. When it comes to maintaining standards and offering quality care, we do have sickle cell management guidelines. These ones will be officially launched this year during the World Sickle Cell Day. So they are supposed to be used at every level of healthcare, from primary to tertiary level. We didn't have any guidance documents, but these ones now will be operation, because they provide evidence-based recommendations for early detection and management of sickle cell disease. As regarding service delivery, more so us in the NCD world, we've realized that integration is the way to go. So currently we are advocating for integration of sickle cell services disease into existing primary care platforms, such as community health services, where hopefully even when we do start newborn screening, an aspect of that can be done. Right now, we're also having it at maternal and child health service delivery points. At school health, we do have a school health policy that has incorporated sickle cell in a bid to train and educate the teachers and the learners, and also want to use it in disease surveillance, and also it's being practiced in the high endemic areas where we use malaria as an entry point to sickle cell disease. We also advocating for the formation and strengthening of patient support groups for psychological and economic well-being. For health information, sickle cell is plagued with the same challenges that faces non-communicable diseases, because we don't have good systems for capturing sickle cell disease cases in the hospital. So for now, we don't even have an outpatient system or variable that captures sickle cell disease. It's a hope that we'll have a registry in the future, but we have done mapping of sickle cell disease, and that's how we know that it's predominant in 17 out of the 47 counties in Kenya. We also have ongoing research in sickle cell, mainly done through the academia and KEMRI. And KEMRI is our National Health Research Institute. What we've also managed to do is, lastly, we continue to integrate sickle cell disease indicators in other national health surveys. For example, we included sickle cell disease in the adolescent health survey that was conducted in the year 2019. This was focusing on adolescents, trying to get to know whether they are aware, whatever diagnosed with sickle cell disease. Yeah. When it comes to health products and technology, which is a key aspect for management of sickle cell disease, we do have hydroxyurea listed as an essential medicine list, and we managed to do this in 2016. And there's an ongoing sensitization of health facility for them to order the essential commodities for sickle cell management together with their supplies. I know one of the greatest issues in this area is the issue of access. More so for the patient side, they are still quite costly. and also the counties, that is a subnational level, are not willing to bear the costs at this point, and most of it is still passed on to the patient. But I'll be later discussing about universal health coverage and how we've tried to bridge that gap. On regarding health financing and universal health coverage, again, I'll draw the same comparison with non-communicable diseases. So despite the substantial health and economic burden of non-communicable diseases, sickle cell disease included, the expenditure is still 5.2%. And this was according to our national health accounts of 2015. This is despite the fact that the deaths due to NCDs are accounting for close to 40%, but the resultant health investment is still very low, which can also trickle down to the one for sickle cell being equally low. How we've tried to bridge this gap is by various avenues, like for example, the National Health Insurance Fund. This is the national investigations for free after paying these $5. So the issue is that especially in public facilities, they might find that they don't have the drugs available. So despite paying the insurance, they'll find that they cannot be given these drugs. Hence, there's a lot of apathy and towards uptake for the insurance, but still most of the families cannot genuinely afford these $5 per month. So in the recent past, the Ministry of Health has rolled out universal health coverage. It first started as a pilot in 4 counties, but last year there was a national rollout, and it's first provision free supply. It's not considered supposed to medicines. Persons living with sickle cell would not have to come constant. So once in a while they have this medicine in facility, but of late we've stayed for quite a long time before this free supply reached the health facilities. Health promotion, a very key area and of importance. So we do continue to offer community awareness and advocacy for sickle cell in partnership with our patient groups, the civil society, and NGOs. So we do, especially in the high burden counties, at least try and educate persons there about sickle cell, and also in a bid to avoid stigma. And then we've also tried as a country, as a ministry, to commemorate World Sickle Cell Day. Although like last year, we tried to do some activities, but ongoing pandemic activities were limited. And this year we intend to also do the same next month. We also have developed and printed some information materials to educate both the general public and also persons living with sickle cell disease on how to properly manage and stay with the disease. Lastly, I think I'll talk about partnership for sickle cell disease. I think this is a very important area. Us as a Ministry of Health, we can't do it alone, and that's why we take it very important that we work with other people. I'll highlight one particular collaboration, and this is a collaboration between Ministry of Health and Novartis, where we did sign MOU and memorandum of understanding last year with a general aim of improving sickle cell health services in the country. And at the end of the 5 years, key proposed deliverables are 6, and these include improving access to hydroxyurea. Through Novartis, we'll be able to ensure that there's constant supply And they've also promised that they've reduced the price significantly so that patients or persons living with sickle cell are able to afford. Then we also want to introduce newborn screening and hopefully roll it out nationally. There are a few sites that have been able to do this, but this is not a program that has been taken up nationally. We also want to establish sickle cell disease treatment centers of excellence so that they can provide learnings for other centers as well. We also, as I mentioned earlier, we have a big challenge when it comes to health information system for sickle cell. So we do want to establish a sickle cell registry. And then we also want to improve healthcare worker knowledge by training them, and especially disseminating the guidelines that we launched last year. And also improve advocacy, communication, and social mobilization in a bid also to raise the profile for sickle cell, even among policymakers and people like who matter and who are involved in budgeting for programs. So this includes parliamentarians and such. So we want to make more noise for sickle cell so that there's more attention given to it. Now, I'll just briefly discuss on sickle cell and COVID because it's a current situation, and I think I wouldn't do any justice if I fail to mention the interaction between the two. So, and I'll do this in form of a demonstration, giving the findings of a demonstration project. The Poverty Commission I mentioned earlier on gave us some funding last year because as you know that persons living with sickle cell disease are at risk of severe COVID infections, and also due to the disruption that was caused by the pandemic itself, the disruption in health services. So there was a need to put some mitigation measures, and we did have this demonstration project that was we received funding from the Global Lancet Commission, NCDI Poverty Commission, which now is a customization of the same at national level. And it was a pilot project to assess suitability of offering sickle cell services at primary level. Most of the services had been offered at a higher level, maybe a sub-county and district level, but not much has been done at primary level. So we wanted also to find out the suitability of such services being offered there. It was a collaboration between various institutions, ourselves, and the metropolitan services. Since health is devolved in Kenya, there was need to collaborate with the Nairobi Metropolitan Services. This is the devolved government because we are going to use their health infrastructure, we are going to use their health workforce, and in some cases, even some of the medications they have. And then we also were collaborating with Sickle Cell Uhuru Trust because they were our link to the patients. At the end of the pilot project, we had 104 beneficiaries, mainly from informal settlements, and the duration of the project was between 2020 to January this year. And we had to develop a temporary tool capture because as I said, we don't have any tool at the moment that captures sickle cell disease. What are some of the lessons we learned? We learned that it's possible to offer a continuum of care to persons living with sickle cell disease at primary level, but it was important that we invest in key infrastructure. And here I'm talking mainly about the lab. When we went into the health center that at that time, that is Kibera, where one of the largest informal settlements is situated, we found that most of the lab facilities were not working. And we thought that instead of having the patients come and then we refer them for lab, and then again making further endangering them and making them more prone to COVID, we just decided to have a one-stop shop, make sure that the lab infrastructure was working. And this greatly reduced the patient cost and also increased the compliance because we knew everything could be done for the patients there. Then it's also important to ensure a constant supply of medications, and this needs a multifaceted approach. First of all, you need a proper adherence from the patient themselves, and also that you need the goodwill of the decision makers, health decision makers. Because one thing we faced after the discontinuation of the project, they were not willing very much to put in money to be able to be supplying, especially hydroxyurea. But this is still an ongoing conversation, because we told them that there have been a lot of benefits that have been accrued. We have more stable patients because of the supply chain being constant. So it's still an ongoing conversation that require that we still need to talk to the decision makers and the people in charge of the budget, so that they again budget for sickle cell medicines. We also saw that on-job training and mentoring is efficient, and where appropriate should be explored to the greatest extent. So when we moved into this health center, we found that none of them had in-depth training about on how to manage sickle cell disease. And we had a physician or a doctor come in from outside and mentor this as they continued seeing the patients. And at the end of it, with the healthcare workers at Kibera Health Center said that they gained the confidence and they were able to now manage sickle cell well after receiving the on-job training and mentoring. And then we also found that mobile phone consultations are an effective way for patient monitoring, especially during the COVID-19 pandemic, when patients needed to be reassured, especially in between appointments. And then for the sickle cell registry, since it was a new tool, and there was the usual outcry at the beginning that this was going to increase their workload. But when we explained that it was an important tool for us to be able to plan well, and we trained them adequately, and we told them that the benefits of maintaining the registry, at least they kept on entering the records as needed. And when we went at that level, they didn't have an electronic system per se. It also applied for the other diseases, but the manual system worked well for us. But I guess in areas where there's a high caseload, it's preferably that this can be done electronically. So I think as I've been going through the presentation, I've mentioned challenges along the way, but maybe I want to break down and give a summary of this. We note 5 main challenges. The first being the poor access to drugs. There's the PenV, progranulin, they are fairly okay, and but they suffer from erratic supply. Challenges on hydroxyurea because of the cost. But again, with this MOU we have with Novartis, things are hopefully going to change. Also because of UHC, where there's at least some supply that happens for free. So this is going to change if we do maintain the constant supply. Then also low laboratory capacity to investigate, especially for HB electrophoresis. So again, as counts in health, in their health infrastructure, this is something we also hope that will change. So for the other supportive investigations, also still a major problem, because for such things as echoes, ECGs, we still have, we are not very decentralized, and especially due to the equipment themselves, and also due to the healthcare workers who are not trained. So, but again, as counties continue to invest in the health infrastructure, this is hopefully going to change. And also as more and more people are trained on how to do these investigations, we expect that they'll be more available as time goes by. Then we also have limited trained personnel, especially the specialists, the hematologists, and we suffer from the same thing where they are more concentrated in the urban areas and none and very few, if at all any, in the rural areas, especially where we have the higher burden of sickle cell disease. And lastly, there is the issue of weak health information systems. We can't at the moment quantify the workload due to sickle cell disease. You can't say how many patients are seen, for example, in each month, each year due to sickle cell disease, because we don't have that indicator in our health information system. But we are hoping that, again, in the short term, be able to revise our outpatient form so that it's able to capture this. While in the long run, we also hope that we will do have sickle cell registry that will even be able to make us collect wholesome data, case-based data on that which will eventually help us for decision making and planning. I think that should term the end of my presentation. Thank you very much for listening and happy to answer any questions. So back to you, Eunice. Thank you.
Saying thank you so much, Dr. Gladwell, for representing Kenya very well. And I know soon we'll be able to just tie all our loose ends and make sure that UHC is working in every area that sickle cell is really needed. And also we'll be able just to understand and get a grip on also if we can get free health cover from NHIF or any other insurance that can take on sickle cell disease. Thank you so much. And it seems we don't have any question. So I think we'll go to the next session. So thank you so much, Dr. Gladwell, and also thank you so much, Eddie.